Thank you very much, Drs. Krishnan and Lazarus. We have a few more minutes left, so right now I will open it up to questions, and I'll hop down and grab the microphone. Okay, great.
I'm one of those poor, hungry doctors, not one of the MDs or DDM. I'd like to congratulate both presenters. This has been excellent. My question, you've given us tremendous information. How do we get this information, especially to those HBC medical schools, the dental schools, and so forth and so on? Because what's happening right now in North Carolina, because of the cuts in budgets, the cuts and all of the other kinds of things, this is fantastic. But how do we frame the economic issue to the folk who are in charge of state budgets to let them know that this is a saving? And you want to, if you can save money while you're cutting money, that's crazy. Could you give us some idea as how we can, in fact, frame this whole discussion? Investment and saving dollars as well as saving lives.
Well, I'll just take the liberty to jump in. On my side, we worked to create a white paper on this issue with an external agency, all annotated by the peer-reviewed literature. Anyone who is interested in that, I think for what we're doing, that would be the best way to get it across, especially to medical schools and state legislators. I'm happy to take anyone's card. Jackie is too. We'll be very happy to disseminate the white paper to you, which I believe this week is also being disseminated to our congressional allies who've been so supportive of proper test reimbursement.
Yeah, I once had a professor who said the way healthcare is financed dictates the way it's organized and ultimately the way it's delivered. And I think what you say is really true. I think in medical schools, one thing that they could have done a better job, I have a bunch of letters after my name. Part of that is I just got very angry with the system, right? The system wasn't working the way I wanted it to do, and so I had to get a public health degree. Then I had to convince people to actually pay for stuff I wanted to do. I needed an MBA. But I think one of the things you could do when you think through the medical school level is that the education around what a value proposition is at a population level, the health economics, no one teaches you that, right? I trained up here at the VA up the street. No one taught me that, right? I mean, at least there they would tell you a little about the costs and how do you take care of a population. Medical students, unfortunately, aren't really trained that way. And so they think about individuals. And that's really, really important. When you're sitting in a doctor's office, that's really, really important. But when you're doing policy or making those kind of decisions, to your point, you have to think about the big picture. And I think we could do a much better job of training medical professionals to do that, whether it's formally or informally. I think that's really, really important.
Claudia Craig Byers. I'm a nurse, and so I'm going to reduce my question to those people that I focus most on, and that's the patient. You both gave some incredibly good information that our communities need. In about 2 weeks, our communities have to have our folks signing up for healthcare coverage. This information that you gave us today is extremely important in enlightening them as to what the cost of not signing is going to be. Do you have an opinion about how those of us who are the foot soldiers to get this information to those patients? Because it's real important, and from what both of you said, it's life-threateningly important. So how do we translate the information you had and translate the attitudes we had from the first panel to our communities so that they go and sign up? Those health navigators actually will get to the communities to understand this information that you're giving us. In my own family, I'm from a family of 16, and in the past 6 months, I lost a sister from colorectal cancer, and I have a brother who's about to face decisions about prostate cancer. So knowing it personally and how rampant it is in the community, how do you suggest we best get this kind of information to the general population level so that they realize it is extremely important that on the 1st of October they become active in the healthcare markets?
Yeah, you know, the best adage here is that an ounce of prevention is worth a pound of cure. And in most states, almost all states, you actually have to get into the healthcare system and have a doctor write something to either get a test or a therapy or even be identified. And so in my mind, it's about the access to care issue, which is that if you have health insurance and you can go in for the blood pressure checks and you can go in for X, Y, and Z, that's going to help you now and then. You may not feel like you have high blood pressure, but it's eating you away. You may not feel like you have high cholesterol, but it's eating you away. If we don't message the prevention aspect of it, it won't work. You know, I go to Best Buy and I buy a TV and they always try to sell me those preventative maintenance plans, right? Like you this or that. But they're very good at that, right? That's the exact same thing that there is for healthcare, right? If you don't have preventive maintenance, it's going to be a big problem. And so unfortunately, a lot of people just think, well, I won't pay for it now, and when I go in the system, they'll just tune me up and I'll be as good as new. Modern medicine has advanced dramatically. We can't make you as good as new. You got to get preventive maintenance or else it's just not going to work.
We have time for 2 more questions.
My name is Craig Cole. I'm from the University of Michigan. I'm a hematologist, clinical researcher. And I want to bring up another healthcare disparity, which is in clinical research. That all of the tests that we use, the targeted drugs that we use, are only as good as the clinical trials which prove their worth.
Yeah.
In multiple myeloma, which I study, where the incidence is twice as high in African Americans than in all other groups, with African Americans having the highest incidence of multiple myeloma in the world, the number of African Americans on clinical trials are unbelievably low, where most trials don't even mention ethnicity as part of the clinical trial that eventually gets to be proven by the FDA as being efficacious, when I don't really know if those drugs are truly efficacious in the population that I serve among African Americans. So I would urge that the disparity of enrollment on clinical trials by African Americans to prove the worth that those fantastic pictures of the chest x-rays would be reproducible in African Americans, people of Hispanic descent and Asian descent, and to have more African Americans enrolled in clinical trials.
I think that your point is so on target. I know for myself, I've taken over clinical trials globally for our corporation. I was head of clinical trials for another major multinational diagnostics firm, and I just want to tell you how resonant what you're saying is. You know, we're poised on a new era of next generation sequencing, and the British Health Service, the United Kingdom, has determined that they will sequence the tumor of every single patient who is positive for cancer in the United Kingdom, and they have bit the bullet, so to speak, and they have recognized that the great advances will occur when we have the same level of care for everyone. And so is it that we must have the same level of clinical research inquiry for everyone. For all communities of color, multicultural communities, we must extend ourselves, not as it's been traditionally, with women as an afterthought, and then rarely even thinking about communities of color. So what you're saying is resonant for me, and it's something I feel terribly strongly about. I'm sure you'll agree that we make these endeavors stepwise in what we do in the research activities at our companies by ensuring that it happens in what we have direct responsibility, and then coming to these forums and working with Congress for things that we don't directly have. I want to tell you that I'm very, very proud of my company. They empowered me to put together what's widely been considered the dream team to really set the stage to focus on funding and reimbursement healthcare disparities. It costs them an enormous amount of money they will never get back in any way, shape, or form. But they shared my vision, my commitment. So that's how it starts.
I think a lot of our research, at least for us, is translational now, which is how do we actually get it in the real world and use it. And what you say is exactly what I preach. We often require additional trials when things come into our health system because of the very issues you mentioned. If I get the results of a clinical trial that has very strict inclusion-exclusion criteria and whatever demographics it enrolled, and I get those results, that's awesome. But I don't know what that means for my patient population, and we are very, very maniacally committed to the right therapy for the right patient, and if they're not representative of our patient population, it's completely useless to us. So I think the answer to your question may be a combination of what Dr. Lazarus said and what I'm saying, which is I think there's a recognition of that on the pre-approval side in terms of how that happens. But I can tell you from a healthcare provider side, if we are unable to understand the issues that you bring up, the therapies are useless to us, right? A lot of what was demonstrated, I think, on one of Dr. Lazarus' slides around who is responding to medications and who is not, is an exact function of what you say, right? Is this discrepancy between who was studied and who the validation was in and who's actually getting the drug. And at the end of the day, I'm here to take care of the patient, whether it's on a one-to-one level or 150,000 patient level. So I couldn't agree with you more.
Thank you.
I have a question about the fact that the research is very important, and what happens, that's after the disease is there. What do you think are the importance of before the disease happens? We kind of like eat ourselves to death, and I don't mean because we may be overweight, but because we're not aware of the kind of foods that we're taking in, whether they're processed foods or not, whether we just throw it in the microwave and just eat it, whether we're sitting at our desk and working and not really getting a full meal, whether or not we go out to the restaurant every night to eat because we don't have time to cook. What impact does that have? I mean, doctors are trained to think about nutrition in the same way they're trained to think about science and chemistry and all those kind of things. Right now people are talking about things like green smoothies. Well, who knew that collard greens didn't need to be cooked? You could actually drink it and get some really good. So how important is it really to train doctors from that level? Because as you say, all these tests and everything, when your patient comes in, you just see them. Like when I get up and go to the supermarket, I see food. I don't, so it's a very simple, remedy. What are we eating and what should we be eating? And are doctors being trained to really take a look at the sequencing in foods that we eat every day that might help us?
No. This is my own experience, right? We are not trained in nutrition given its relative importance the way we ought to be trained, and we don't ask those questions when people come in. DaVita employs a literal army of dietitians, right? We have 1,800 dietitians, and it just amazes me at the amount of interventions. One of the things that patients who have high blood pressure and renal disease have to be very careful about is salt and phosphorus intake. And that has nothing to do with medicines, right? I can give you medicines, but it's much better that you eat the right thing. And they've really just educated me on exactly what you said, which is the training that I've had to take care of individual patients for nutrition is not just pales in comparison. And so it's critically important, right? Because you can give all the medicines in the world, but if you're not on the right diet, you reduce the efficacy of those medications. At the end of the day, we want those medicines to be maximally effective. Any outcome in medicine is due to one of three factors: the patient, the provider, and the disease. Unless all three are in perfect alignment, the outcome is not guaranteed. And the patient in that is a huge factor. So I couldn't agree with you more.
Just a very, very quick answer, because I know we're out of time. My mother is a master's prepared dietitian. She's 92. My father's 90. She's always had the same consistent outlook. She taught medical students, nurses, and house staff, and she always said the same thing. If it comes in a box, avoid it. If somebody wants to fry it, broil it. And go shopping and get fresh fruits and vegetables. Now, I just want to say 2 quick things. If you don't know how to go shopping, then no matter how your doctor or a dietitian can say that to you, if your mom didn't do that, nobody trained you how to do it, then it's almost impossible. So I'm happy to see that there are many inner city programs that are springing up to train folk on how to properly select fruits and vegetables and prepare it. My very last comment, you gotta keep your teeth up because everybody knows that the difference in taking in nutrients, if you have your own teeth compared to not having teeth, to having teeth that are, and gums that are not functioning compared to having dentures, it's night and day. So nutrition starts by mastication efficiency and taking in those good juices of those fruits and vegetables.
Thank you so much for your thoughtful questions. Please join me in thanking Drs. Christian and Lazarus for their wonderful presentations and their thoughtful answers to your questions. They will talk about the purpose of PCORI, as well as the health disparity elimination priorities and recommendations that have been set by, and the challenges that have been identified by PCORI. And just as our last session, it will be followed by a question and answer session. So, without further ado.
Thank you very much. My name is Tony Coelho, and I first off want to thank the Congressional Black Caucus Health Braintrust for inviting me to be here today, and especially Congresswoman Donna Christensen. Donna not only had the vision for this panel, but she really worked hard in the House of Representatives to create PCORI, which stands for Patient-Centered Outcomes Research Institute. And she really understood what it was all about, was putting patients first. And Donna did a great job, and I personally appreciate all that she did. It's also great to be here with my friend, Dr. Frida Lewis-Hill. Frida has done a great job at PCORI, trying to eliminate the healthcare disparities as a result of PCORI, as being a PCORI board member. She's very active, works very hard as a board member, and that's a great credit to her. Some of you might be familiar with my work on behalf of people with disabilities, as I was the author of the Americans with Disabilities Act when I was in the Congress, and my passion for making our healthcare system more responsive to the patients as it is intended to serve. As an epilepsy patient myself, I understand more than most how information can be used to make the healthcare system better and how it can be used to limit people's healthcare choices if left unchecked to perpetuate the one-size-fits-all mentality of the current research system in the federal government. I represent a group called Partnership to Improve Patient Care, also known as PIPSI, which is a coalition of patients, providers, industry leaders, and other stakeholders. Several of the PIPSI members are in attendance today, including Andrew Williams from the Association of Black Cardiologists, and we appreciate Andrew's help and cooperation in our group, and Andrew Sperling with the National Alliance on Mental Illness, and we appreciate Andrew's help as well. PIPSI was a strong advocate for the provisions in the statute that provided the check on PCORI to ensure that the Institute is truly patient-centered and really even patient-driven. By keeping patient interests at its core, we knew this was going to be a paradigm shift in the way research is done. But changing the culture of research is not an easy task, which I expect Frida to address when she talks about her experiences as a board member. To that point, I was asked to talk to you about PCORI's purpose, its work in eliminating health disparities, and its overall progress and challenges. I'll start with PCORI's purposes. PCORI statute states its purposes extremely well. The underlying principle of the Institute is to provide patient-centered, evidence-based information to assist patients, clinicians, purchasers, and policymakers in making informed health decisions. Unlike other federal research organizations, PCORI is mandated to consider variations in patient subpopulations and disseminate findings based on what works for individual patients. In summary, its work is intended to not look at clinical effectiveness in the context of averages, because none of us is really an average. In terms of working to eliminate disparities in healthcare, PCORI has made addressing disparities one of its national research priority areas and has funded several projects within that research area. More importantly, PCORI has asked all of its contractors to focus on subgroups and not just the averages when conducting research. Additionally, an advisory panel on disparities was established to help prioritize PCORI's research agenda on specific studies that will best eliminate disparities in our healthcare system. I would imagine that Dr. Lewis Hall is in a better position to discuss the specifics of these projects that are being funded relating to disparities. Instead, I would like to focus on PCORI's progress and challenges in meeting the statute's broad vision for eliminating disparities through patient-centered research. Changing the culture, as I've said, is not easy. Traditionally in the government, research topics are usually driven by researchers, and the researchers do not always adequately engage patients and providers, if at all. Therefore, research findings, although perhaps interesting, aren't always particularly useful to the point of care for patients or clinicians, especially for people in subgroups that tend to receive desperate care. PCORI was created by Congress to change that dynamic, to be different, to engage the patient each step of the way, from developing the research agenda to establishing a study design to disseminating the findings. Therefore, the members of my group were disappointed when PCORI began a process for funding research projects that followed the traditional research pathway, one that was driven by research, not patients. PCORI refers to this as their broad funding announcement process. While we often first hear from patient groups that are excited to be approached by researchers to be their patient stakeholder partner on an application, we later hear from them that they were not engaged in choosing the research topic and do not feel meaningfully engaged in the research process. Despite PCORI's good intentions to require research applicants to engage patients, allowing researchers to drive the process means that patients are often sidekicks in the process, are used just to get the money. But after hearing from patient advocates and leaders like a lot of you in this room, PCORI has recently recognized this problem and created advisory panels that include patients and providers to narrow down a set of specific research questions. Although we would like to see improvements to the advisory panel process, it is a step in the right directions. And I would add that some of PCORI's staff recognize this problem personally and have tried to address it. What makes PCORI really different is the inclusion of patients at the table for a vote, meaning patients on their board. This is the first time this has ever happened with any of the federal agencies. PCORI has had many meetings intended to engage stakeholders, which is progress. But the challenge is getting PCORI to engage patients earlier in the decision-making process and to translate the feedback received into their practices and operations. One such example is a recent PCORI roundtable on dissemination practices. Even though PIPSI and other leading patient advocacy organizations has communicated many times the importance of this issue for our members, there was little representation among patients at that roundtable. We must continue to push PCORI to focus on its original mandate to engage patients and providers throughout the process, but they are making progress. I give PCORI significant credit for its recent work to engage people with disabilities. Last year, PCORI held 3 roundtables with organizations representing people with disabilities. As a result, we learned of research going on at PCORI that potentially would benefit us. Therefore, PIPSI and the American Association of People with Disabilities co-hosted a follow-up roundtable discussion to come up with specific recommendations to PCORI on what would work and could be doing that would have a true impact on those of us with disabilities. And now we are working to schedule follow-up meetings with PCORI to help them better understand the areas of research importance in addressing healthcare disparities and directing participating organizations on going out and find their own researchers to go after PCORI funding for the projects that we have identified. PCORI in that process engaged a group of patient stakeholders who now will move ahead to bring meaningful research ideas to PCORI. This is what it means to be patient-driven. We want to see PCORI doing more of this. The law requires the GAO, the General Accounting Office, in its 5-year review of PCORI to discuss the overall effectiveness of PCORI's main mission, including reducing patient variation and disparities in healthcare. As long as their work is patient-driven, PCORI should be able to demonstrate this potential. In closing, I'd like to emphasize that PCORI is full of well-intended people that are sincere about improving our healthcare system. I would say they are making progress. Yet I would urge you to closely monitor PCORI's work to keep them on the right track envisioned by Donna and the rest of us that helped in authorizing the statute. Thank you very much.
Let me echo the gratitude for being able to be with you today. Over the years that I've served on the PCORI inaugural board, it's been quite interesting. My friends and family didn't know what it was, and at every chance and opportunity, I have to remind them. And so being here with you today and extending our PCORI friends and family is really a wonderful opportunity. Make sure I'm, okay, want to make sure that I'm touching the right thing. What I'd like to do is really a couple of things. What I'm most interested in overall are your questions and your comments, your concerns and your challenges around the work that PCORI is doing. But I'd like to take just a couple of minutes to frame who we are and what we do. I also want to take just a mini step back to say that PCORI's work is in the context of other important efforts that are afforded us by the Affordable Care Act. So if you ask yourself, what are health disparities actually? Disparities in health status and disparities in the quality of care. What are the major drivers of that, and what can we do about them? So one of the first and largest problems is having inconsistent data, not having the data to analyze, to understand what is it really that drives a wedge between these better outcomes and poorer outcomes. And so a part of what is strengthened by the Affordable Care Act are the data collection requirements and data standards by the OMB. So we anticipate that we'll have better data to work with. The second is the low visibility for groups who address health disparities issues. And again, we now have an opportunity where many of the programs and platforms that have stood for many years and worked very aggressively towards closing gaps in health disparities now have institute status. Their visibility is raised. Their ability to do things is now differentiated, and we hope and expect to have better outcomes in closing the gap as a result of that. The third is that we haven't really consistently or in a coordinated way necessarily worked on new service and delivery models that may be required to close the gaps. Often, Dr. Lazarus's points are very well made. As someone who's been in the pharmaceutical industry for many years, I often say we're developing Star Wars technology, but we're delivering it into the Flintstones healthcare system in many cases. So the question is, what is it about the model that can be improved so that we have Star Wars tools and a Star Wars system that allows us to deploy it in the best possible way? And then last, but to my mind definitely not least, is the opportunity to generate data that helps us understand what actually works in closing the gap in health disparities. So we've done a lot of problem elucidation. What we haven't done is consistently test and disseminate information about what drives those disparities and what can close the gap. So PCORI is empowered to do just this type of research. So let me remind you who we are, the Patient-Centered Outcomes Research Institute. We are an independent, nonprofit research organization that was authorized in the year of 2010 as a part of the Affordable Care Act. We are an independent, nonprofit research organization. We're committed to continuously seeking input from patients and a broad range of stakeholders. We think that that makes us wildly different from the current system in academia, in pharmaceutical, diagnostic, and device industry, what currently goes on in publicly funded research. Much of that is driven by the brilliance of researchers who have important ideas that need to be tested that drive incredible results. What we often neglect is asking the people for whom we desire those wonderful results if they really care. So, I go back to, with my children, I would come up with these wonderful games for them to play when they were young. That didn't last very long, because they would tell me, slow down. We should be telling you what's fun for us. You shouldn't be telling us what's fun. And so that's what we've really done. And as a patient myself, as a caregiver for many, many years, for family members and friends with very serious chronic or acute illnesses, I can tell you that in many cases, the information that you want as a member of a healthcare team, as a patient or a caregiver, just doesn't exist. And that is the role of PCORI, to ask healthcare providers, patients, payers, informed, supported, and turbocharged by the techniques and methodologies of brilliant researchers to answer those questions. This is who we are. We're a very diverse group, mandated in many ways. There are 3 of this and 2 of this and 5 of those. We represent the entire healthcare system packaged in 21 people. We have a great range of diversity of experiences and backgrounds, and remarkably, with all of those differences, with a single goal in front of us, we've galvanized very quickly and are moving the agenda forward. So what was the agenda? We had 4 remits. One was to establish national research priorities, and I'm going to tell you a little bit more about those in a minute. We were also asked to establish and carry out the research agenda. So what do we need to get done, and then to develop a more specific agenda of how we're going to get it done. We were also asked to update and develop methodologic standards. I said that we needed to be turbocharged by really elegant science to answer the important questions. And so there's a lot of talk about what methods should be used to answer questions. And we have an incredible team of 17 world-renowned experts in methodology that work with us every step of the way to set standards, to elucidate standards, to educate, to inform, and to help us shape research projects that are going to be fit for purpose in answering these important questions. And then last but not least, and someone asked earlier the money question, right, which is, okay, all this information is great. What you going to do about getting it to the people who really need it? And so we have a robust effort around dissemination of those findings in collaboration with others who disseminate as well. I'm not going to go through our entire research agenda, but we have 5 key areas that we're focused on. The assessment of prevention, diagnosis, and treatment options. I know that's a broad topic, but it's an important one, and we're prioritizing in this category and working to answer questions that we think will advance overall better health outcomes for all. Improving the system, I mentioned, what good does it do to have these incredible tools but not be able to use them when they're needed? And so we're doing work on understanding our system as a tool and finding ways to refine it and improve it. Communication and dissemination, I just mentioned, again, important. Doesn't do any good if you have the information and it doesn't get disseminated. And just to give you a statistic around how important this work is, on average, it takes about 15 years to truly integrate a research finding into everyday practice. So depending on where you are, the likelihood of you actually deriving the benefit of important research output becomes lower and lower and lower. And so we want to find a way to speed that, not just improve the research itself and make it more pertinent to patients, but to also speed getting that research into the hands of the people who need it. Our 4th agenda topic is addressing disparities, and I'll talk to you a little bit more in a second about that. And last but not least, accelerating that methodologic work that I mentioned before. So, how are we addressing disparities? First is understanding the differences in effectiveness across groups. A physician from Michigan specializing in multiple myeloma just asked an important question, and that is, that data is fine, but is it relevant to my population? That's really what this question is about. And we know that this becomes important. For years, I've been involved in health disparities for, well, let's say a little while. And one of the important things is we've said that it's the right thing to do, and it is the right thing. It is also the scientifically appropriate thing to do. And so this is an opportunity through sound research in PCORI to help us understand how different populations are affected by the work that we do in our system, by the treatments that we deploy, whether or not diagnostics are meaningful across all. And that's what this, few words actually speaks to. It's a large body of work. We also want to understand the difference in the preferences across groups. So some of it is the hard, cold science and just is what it is. But depending on who people are, where they are, how they receive their health care, we have preferences all along the way, where we get our data, who we seek our health care from, how we receive that, how we respond to it. All of those things create differences in how well or not well, at the end of the day, our health outcome results turn out. And then last but not least, we really want to actually reduce health disparities. So generate the data, understand how to deploy it through good dissemination, and then actually close some gaps. So how did we plan to do that? Actually, let me go back. We've deployed a council to help us focus very specifically on addressing disparities. They've been convened, they've looked at 12 topical areas, and have ended up narrowing in on several that we think are really key right out of the gates, such as hypertension, looking at patients who are, or perinatal mortality and perinatal outcomes. So our death rate for babies is extremely high across many communities, and we have a lot of work to do to close those gaps. Looking at risks in cardiovascular disease, lowering the rates of lower limb amputation, which just for African Americans is 3 times the national average, 3 times. So if you look at just these few 5, you find yourself in a place where you can make a tremendous difference in health outcomes for a number of people. So this group is looking specifically at that work, but we're also making sure that across our entire portfolio of research that we're including racial and ethnic minorities, different genders. We're looking at socioeconomic and demographic factors to make sure that all of these things are given consideration. And of the 147 or so grants that have been completed or have been let in our time across our 3 cycles, just shy of half of them very specifically additionally address the inclusion of racial and ethnic minorities in that work. So we think that's an important milestone. I also want to make sure that I share with you, because I get in this, I told you I've been in this for a while, and a lot of people say, okay, that's great, y'all are doing some great talk, you got some nice slides going and everything, but where are you spending your money? Because that really tells how important this becomes. In our first round, we actually had 4 awards. Our group wasn't quite up and running yet, but I told you that our entire intent was to address disparities. So about 6% of the total awards that were let during that time period actually applied or addressed our disparities issues. In cycle 2, we were up to 14.7%, almost 15%. And I'm checking because I just got hot off the presses what we have in our last cycle, which recently closed. And that is, we had 9 awards during that period, which actually amounted to about 18% of the total award dollars that were generated at that time. So we think that we're directionally correct. More and more, greater and greater focus, deeper and deeper information, cranking right along. And then, last but not least, I want to mention that we've also done a set of targeted awards. Tony rightly mentioned that our first award group of grants was very general, if you would. They were, our primary group of grants was general and quite dispersed. Our second was what we call targeted grants in 3 areas. The first was preventing falls in the elderly, not specifically targeted at a disparity issue or a specific population, but certainly addresses a keen issue in the African American population. Uterine fibroids, which also disproportionately affects African Americans and other minorities. And last but not least is the one that you see before you on the slide, which is a specific grant that targets treatment options for African Americans and Hispanics with uncontrolled asthma. So that grant, actually our intent letters were due on August the 1st. We actually received the grants on September the 18th, and we are feverishly reviewing them now. We are thrilled about this because we know that this is deadly, and Dr. Lenore spoke briefly about that earlier. And then last but not least, truly last but not least, we are inclusive. We want you to email us and call us. Our meetings are open for those of you who live in Washington. We have an upcoming meeting early next week. We invite you to come, listen to our deliberations, give us ideas, course correct us if you think we're going astray, And if you want more information about us or to take an opportunity to comment, please go to www.PCORI.org. And I look forward to hearing from you and/or seeing you all at our upcoming deliberations. Thanks so much.
Thank you very much to our panelists. I think we have a few minutes for just a few questions, if there are any in the audience. Okay, so we'll take one in the front and one in the back right here.
Just as a question, you said you were totally inclusive. Is there a dentist or is oral health included in your, in your board?
So yes, we do not have a dentist on our board, but we have invited the oral health argument. And understand, I know we've been using the notion that the mouth is the gateway to the body, and I guess the eyes are the windows to our soul, and recognize that those two things actually are often not included in the work that happens in many research platforms. So we have given that consideration, and it's especially important as we look at health disparities, because if it is a problem for the general population, which it is, it's a mo better problem for us.
Absolutely. So our organization would be willing to, work with you, and if you would reach out, we'd be more than happy to work with you in terms of trying to develop some research projects.
So I think you just volunteered. I'm gonna do you one better. Don't go before I get down from this podium, and we'll make sure that I get all of your contact information.
Hey, thank you very much. Congratulations on the excellent work. One of the things I like to say is I went to your website and I saw that there were some ancillary looks in terms of things that you would be willing to consider, and one represented connected care, mHealth, most notably telemedicine. I think that's excellent, particularly on the rural populations. The inherent limitation to me with respect to telemedicine is that it tends to involve one patient, one clinician at a time. I would really encourage the PCORI group to consider looking at wireless healthcare as well, most notably the ability to impact multiple individuals with a single clinician or a single practice at a single time. I truly believe that with respect to chronic care management, you talked about hypertension, diabetes, obesity, the future, or at least one of the futures of healthcare, clearly in taking care of patients, a lot of these individuals are going to be ethnic minority patients, will be with wireless healthcare. There's no doubt that AT&T, Sprint, others are investing billions of dollars there just because of that. But I think there's going to be an opportunity to really look at some things and to do some great studies in that environment as well. Thank you very much. Keep up the great work.
No, thank you. Did you want to do that one? So I think I have done some work outside of the U.S. as a virtue of my personal interests, but also as a part of my roles over time in research and development and medical. It's really interesting that for us in the U.S., we have been leapfrogged by many other countries in their application of mobile health. And there are tremendous examples how in the remotest of areas we have deployed health interventions using mobile technology. And one of my favorites is actually happens in India in quite remote villages, back to eye care, just not enough ophthalmologists to take care of everyone in India, not even almost. And so the solution was remarkable, using mobile technology and training high school girls to use that technology to triage patients by doing diagnostics. So sophisticated applications. These young women are highly trained in their villages. They use their phones, if you would, and other connectedness, and are able to send the pictures back that are then either from digital functional recognition platforms or through the eyeballs of professionals who are sitting in faraway cities, are able to diagnose and bring patients in for more sophisticated care where it's necessary. So that is a tremendous example to me of how you can take what everybody seems to have everywhere, and to use it. And there are probably, 1,000 examples of important work like that. We at PCORI are interested in accumulating these wonderful ideas and synthesizing them and testing them in the therapeutic areas with people who are different from one another and have different needs, and come up with ways that we can then deploy in the best possible way.
They focus, forgive me, the Pew Foundation study on internet studies in the United States of America, looking at ethnic minorities, focusing specifically on black folk, Latinos, and Asians, indicating that ethnic minorities utilize the internet for healthcare services at a greater rate than do other individuals within society. I truly believe that the future, one of the futures of healthcare in this country, clearly is going to be on mobile strategies, as you pointed out, connected care, and the utilization, ladies and gentlemen, of the text message. That's where it's at. The ability to communicate both ways, the clinician to the patient, and the patient back to the clinician, utilizing the text message. So thank you very much.
Thank you very much.
By the way, don't go out the back door now. You just volunteered too. So.
It's okay.
Okay, let me get your card before you go. Another volunteer. This is good. This is good.
Thank you. We have time for one more question, so.
I want to volunteer too. So I'm Tina Hone from the Lung Cancer Alliance. Thank you for the great panel. Thank you to the Congresswoman for always doing such a great brain trust. We have a challenge in the lung cancer community. Lung cancer is the leading cancer killer of every racial and ethnic subgroup. In the African American community, it kills more African Americans than breast, prostate, cervical, colorectal, and pancreatic cancer combined. But because we don't fit within the traditional definition of a disparity, it's very difficult for lung cancer to get the attention that it needs and deserves. And so we've been looking at PCORI backwards, forwards, sideways, inside out, to figure out where we can fit in to have a meaningful conversation about this leading cancer killer. 160,000 lives a year, 60,000 of those lives are African American lives. Any advice, guidance? I volunteer to help you work on it. But really such an important issue. We're at a breakthrough moment with lung cancer screening, getting the positive recommendation from USPSTF, but there's still a lot of work to do. And if screening doesn't get deployed equitably, we will have a situation where we really do have a disparity, because people who get screened have a 92% chance of surviving lung cancer if it's caught early. Thank you.
You raise a, where is it? Is this on? Can we get it on?
Yeah.
Oh, there it is. You raise a great question. Frida does a tremendous job on the board, so you all should be supportive and appreciative of what she does. But I just want to point out, your question is at the heart of PCORI's problem. And that is, groups like yours have a hard time convincing PCORI that they need to help you develop the research opportunity. They are struggling with trying to get that done. So don't be so sure that you're going to be able to go there and you're going to get a grant to study anything, because that ain't going to happen. Now, they are moving in that direction and they're getting better at it, but there is a real problem of how do they bring you to the table in order to develop that research opportunity, because it does exist, you're right. The point I was making before is that to a great extent, if you take ARC and NIH, the researchers control what research is done, as Frida pointed out. At PCORI, it's supposed to be the other way around. The patients are supposed to do it, and the researchers are supposed to do the research that the patients decide is what should be done. That ain't being done right now at PCORI. It's what the PCORI board would like to see done, and they're advocating that it be done, but it ain't being done. And so what you all folks need to do is to stay after Frida to keep pushing the management of PCORI to get that done. That's what we're trying to do, and that's what you need to help Frida get done. But what you're pointing out is exactly the problem. It affects the African American community, it affects the Hispanic community, it affects everybody, and that's the type of research we should get done. The patients need a voice. We don't have a voice in NIH or ARC. We do have a position at the table in PCORI. That's what it's all about. That's what makes it exciting. You're right on target.
So I appreciate that you volunteered, and Tony's point is exactly right. We've had the challenge of, one, prioritizing, two, having partners at the table that are able to actually deploy or to shape research first and define the research question, and then to actually put a research project on the ground. And we found more and more, as you see that our data indicates, but not nearly enough. So we know that our job isn't over. And in particular, with lung cancer, it is critical for us as a community to ask and answer questions all along the way. Our smoking puts us at risk. Our diet puts us at risk. Our lack of exercise. So there's a prevention aspect to this that we have an opportunity. And then, to your point, the screening opportunity for us to recognize, routine screening if and when that becomes more widely available, I'll say. And then last but not least, Dr. Lazarus pointed out an unbelievably important point, which is if prevention is the best and early detection is the next best, then getting the appropriate diagnosis at the molecular level, kind of using the Star Wars technology to know if you're EGFR or ALK or, whatever positive. So it becomes important for us to advocate at every single step. And PCORI has a role in helping to shape whether or not we have the right data, we have the right information, and we have the right approaches to get the best outcomes from all of those things. So I'll have all three of you right there at the back on my way out to make sure that I have all the contact information, and we look forward to seeing you.
I have one closing comment I'd like to make, and that is on dissemination. Frida and the board is addressing this, but let me tell you what the real problem is. A lot of the researchers, particularly at the universities, and it'll make somebody mad here, I'm sure, but a lot of the researchers, particularly at the university, are in their ivory towers, and they do this research that doctors and patients can't understand. And so it's great to provide money to researchers. If nobody can understand it, why in the heck are you doing it? And so one of the things that PCORI has been directed to do is to make sure that this research is usable. Not only that you can disseminate it, but that it is usable for the patient and the provider, for the doctor. And then to make sure that you can disseminate it out. But you can disseminate bad research or not understandable research. So make sure that you get research that is understandable. So that's what, PCORI is a great idea, and it's a great instrument, can really help a lot of people. If done right, that's PCORI's job.
Thank you so much for your thoughtful questions. Please join me in thanking our panelists for their presentation.
Thank you both. We ran a little bit over, but I thought the information was really important to share. Don't you agree? Yeah. This part of Affordable Care Act was my most difficult day on the committee. It was like a long, hard labor, but the product of that birth is really made it all worthwhile. We're going to move right into our next panel, and then we're going to gather lunch as we get ready for the next one. But we're going to do this panel first. Our original moderator is near delivery time, and we thought, based on what was going on with her this morning, she thought, and we agree, that all of medical people in here, we really didn't want to have to do a delivery. So we're really pleased that Joycelyn Tate could step in on short notice. She's a policy consultant specializing in providing strategic advice and advocacy on telecommunications and technology policy issues. She serves on the Executive Committee of DiversiTech, an organization that provides diverse communities. And Joycelyn, you can come up, and we'd like your panelists to also start coming up. She's the host of Telecom Talk on Flow Radio, where she discusses technology and telecommunications issues. I'm sure the discussion a few minutes ago was very interesting to you. She's recently served as a member of the U.S. delegation to the 2012 World Conference on International Communications in Dubai, was appointed by the chairman of the FCC to serve on the board of directors of the Universal Service Administrative Company, and she's the former director of telecommunications policy at the Minority Media and Telecommunications Council. She is also a product of the CBC. She served on the staffs of both Sheila Jackson Lee and Donald Payne, and at the Wireless Telecommunications Bureau at the Federal Communications Commission. She earned her Bachelor of Arts from Howard and her Juris Doctor from Columbus School of Law at the Catholic University of America. And thank you so much for stepping in to moderate this panel, and turn the mic over to you.
Thank you, Congressman Christensen. Good afternoon, everyone. In the interest of time, I'm just going to mention the names of the panelists that we have with us today, and you can read their bios. They're in your program. First of all, we have Ms. Nima Patel, and she is the franchise director at ISIA Incorporated. And then we have Dana Mendenhall. She is the Director of Solutions and Therapy Marketing at Baxter. And we also have to my far right, Mr. Ted Kell. He is the co-founder of Conscious Health. We can open with Ms. Patel.
Thank you. Good afternoon. Glad to be here, and thank you for inviting me to participate. Participate on the panel. I actually have over 18 years of experience within the pharmaceutical industry, with marketing experience in a variety of different therapeutic categories. And marketing goes beyond just what you see in magazine ads or TV commercials. It's really important as marketers for us to, I have to compete with them, so hopefully I can do a good job. I know I can speak really loud, but we'll see. Is it good? Okay, thank you. So it's really important to understand our role and the part that we play in disease education, which is a big component of what we do. And it's important for us to understand how we get our information and disseminate our information out to the populations that we serve. And so again, for us, the big insight is, one size does not fit all. So we have to truly understand how our customers like to get information, how we communicate our messages so they resonate with the audience we're targeting, whether it be consumers or whether it be healthcare providers. That's a really important component. I work for AZI, and our corporate mission is about putting patients first and caregivers. And our CEO supports us dedicating 1% of our time to interacting and engaging with customers. And it's so important for us to do that because he wants us to bring those learnings and lessons back to not only marketing, but also product development as well as innovation, so we can learn about the unmet needs that exist in the marketplace, as well as the gaps that we need to address. And just a quick example of how we are helping to support health equity, as well as helping to eliminate health disparities, is through our partnership in the oncology space with the Sisters Network. It's important for us to increase awareness of breast cancer among teenagers. That's important for us. We're working with the Girl Scout troops so that they understand and are educated on breast cancer, and they can take that information back to their mothers as well as their relatives. So again, that's just one example in which our company is playing a part, but there's definitely other marketing opportunities that we will talk about today. Thank you.
So good morning as we await the masterful technician. My name is Dana Mendenhall, and I have the privilege to serve at Baxter Healthcare in our renal franchise. We have responsibility for our peritoneal dialysis portfolio. In their absence, but certainly noteworthy, yes. I wanted to take a moment to just commemorate the work of Congressman Christensen, as well as Dr. Weinstock for the Health Braintrust. Because of their passion and because of their work, big corporations like Baxter Healthcare are now raising our hands to say, hey, we want to partner with you and we want to join you in this health equality fight. So thank you both to them, and wish they were here to hear that. So I know that we have a lot of MDs and PhDs and health equality advocates in the audience, and I also know that you know how taxing hemodialysis can be on the body and on the cardiovascular system of a patient who lives with kidney disease. And quite frankly, when we look at hemodialysis in comparison to peritoneal dialysis, many of the quality of life and clinical benefits are not present. So I'd like to ensure that as we go through this discussion today, you truly have a background of where we are. When you think about the life of a hemodialysis patient, and if it has not impacted you or someone you know, friend or family, first count it a blessing, but also ensure that you know that when a patient is committed to hemodialysis in center, this means that they are committed to traveling to a facility 3 times a week, and each time there spending 3 to 4 hours to have dialysis performed. What it also means from a clinical standpoint is when you look at residual renal function preservation, improved survivability, as well as improved preparation for transplantation, it's absent for certain patients in the hemodialysis space when compared to those with peritoneal dialysis. Simply put in layman's terms, when we look at the in-center patient with hemodialysis, they are living to be dialyzed. And we look at the peritoneal dialysis patient, they are being dialyzed to live. And that's a huge difference. And right at that difference is where I'd like for us to dig into the data. So as marketers, when we look at the peritoneal dialysis space, there are about 365,000 patients total who receive some form of dialysis. As we look particularly at PD, the penetration rate is about 8.8%. However, as marketers, when we segment this data across ethnicity, a very different but unfortunately, a very common story is told. African American patients under-index significantly in PD therapy when compared to other ethnic and non-ethnic patient populations by greater than 2.5 percentage points. And that's extremely important because what that means is that at least 3,500 potential patients are not accessing the quality of life and the clinical benefits that are offered by PD therapy. As we as marketers go a step further and segment the data across geography, the story may be as simple as your address may impact your access. Imagine your address impacting your access. A study done in 2011, and this information is in your packet, the sources are there so you can follow along, but I will highlight it here. In 2011, there were higher proportions of PD utilization in the states of New York, North Carolina, Georgia, and Texas. And despite those very important wins, when we look nationally at the trend, these states still are not above the 8.8 penetration rate for PD utilization. When we go a step further, less than 1% of African American PD patients reported having access to the benefit of this therapy in Alaska, Hawaii, Idaho, Maine, Montana, Oregon, Utah, and New Hampshire. And the story gets a little bit grimmer here. There's no PD usage being reported through this study in the states of Wyoming, Vermont, and South Dakota. Conversely, as we look for a role model, as we look for a benchmark, we look to the District of Columbia, where African American patients who utilize PD therapy are outpacing Caucasian patients. And then secondly, 50% of all PD patients in the state of Georgia, Mississippi, and South Carolina are African American and are accessing PD therapy. It's important to note that PD therapy is a very viable option for patients who live in rural geographies. And most importantly, what it does is it eliminates the necessity for the right patients to have to travel to an in-center facility that services hemodialysis patients. Again, 3 times a week, 3 to 4 times each visit until either death or transplantation. Baxter Healthcare is the therapeutic leader in the PD space in the U.S., and we continue to grow, but despite that growth, the disparity for African American patients still lags the national average, as I previously shared. We have the opportunity to serve over 25,000 patients, which represent about 76% of the marketplace. And I will transparently tell you that until now, our growth strategies did not explicitly target African American renal patients. Quite frankly, we unintentionally excluded them from the conversation by not explicitly targeting them. So we again thank Congresswoman Christensen and Dr. Weinstock for their innovation, their passion, and their work. And this is why we are here today to join into that fight. Explicitly, our growth strategies will now tackle culturally relevant insights for ethnic patient populations. And yes, we are going to go a step further than grabbing a graphic of an African American physician and a graphic of a Hispanic patient and just including them in the brochure and saying, yep, we got it covered. That's not going to help us grow the way that we are called to grow as an organization. We recognize that if we're going to successfully address this patient population, we have to do so in their language, on their terms, in their preferred modems, and reach them where they want to be reached. Dr. Gary Puckrin came to Baxter back in April during Minority Health Month, and he put us on our toes, and he made us understand that this disparity is not only quite embarrassing, but is not acceptable for Baxter Healthcare. So as a result of that, and partnerships throughout our organization, we've been able to secure record funding to go after this disease state and to focus explicitly on African American patients. And I hear some of you saying, hey, it's a little late, but I'm saying from Baxter, it's right on time and it's the right focus for us. So we are committed to simultaneously addressing underserved African American end-stage renal disease patients while creating both employee and patient value, which will ultimately create shareholder value. And again, this is important because one of the best kept secrets in corporate America goes a little bit like this. Where there isn't a dialogue, there isn't data. And where there's no data, there's no dollars. And when there's no dollars, disparities exist. And so Baxter is committed. I'm sorry, this computer's a little bit different than what I'm accustomed to. We are committed to addressing this disparity for African American patients. We will explicitly go out and conduct a market research assessment that helps overcome the barriers and to provide insights to end-stage renal disease patients. And I hear you PhDs in the audience saying, are you going to conduct market research where we get one representative from the state of Texas and expect them to understand the experience in Los Angeles, in South Dakota, in the District of Columbia, and all the way in Kalamazoo? Well, absolutely not. Quite frankly, we're going to do research, ethnographic. We're going to do in-center triads, et cetera, with patients, physicians, nurses, caregivers, community leaders, congressmen and women, and also non-ethnic minority serving physicians. We are going to target 5 states, and they are listed here before you. These states were chosen because of their proportion of in-center hemodialysis when compared to peritoneal dialysis. We are going to exploit the hypothesized barriers such as institutional biases, microeconomics. The list goes on and on. You are aware of that. Poverty, age, etc. And then we're going to execute these solutions in these 5 states that we've identified. And once we have successfully achieved our pilot metrics, we're going to roll this out.
Well, I'm Ted Kyle, and it's a real privilege to be here to participate in this panel about corporate partners in health equity. I am vice chair of a patient advocacy organization called the Obesity Action Coalition, and also founder of Conscious Health, which I started after 26 years in the pharmaceutical industry, working in marketing and advocacy, both in prescription pharmaceuticals and in consumer health care. And I just want to reflect for a second to set up the discussion on some of the experience that I've had in partnering with underserved communities. And that would involve work in HIV treatment, really back before there were treatments for HIV, in HIV testing, in smoking cessation, and in obesity and weight management. In HIV treatment, as I mentioned, it was initially untreatable, highly stigmatized, and it almost exclusively affected some seriously disenfranchised populations, as you know, but very diverse populations. So working with antiviral therapies, at that time the company I was working for was called Welcome, and they helped to develop some of the first antiviral therapies for HIV. Trust and collaboration was challenging, and it required a great deal of effort and a lot of trial and error to get to a place where we had good, productive trust and collaboration. Then in HIV testing, at that point in time, therapy was evolving. HIV was evolving from a uniformly fatal disease to a chronic and manageable disease, and that evolution in treatment made testing more important. There were still, though, substantial hurdles due to stigma and discrimination. So partnerships built on trust in terms of offering innovations in testing were absolutely essential, and some of that work led to the oral testing, which you see being made available now for home HIV testing. Also worked with smoking cessation, which has really addresses a very disparate impact of tobacco dependence on underserved populations. A prevailing emphasis in smoking cessation is really on prevention, we found, but it was essential to understand and work with communities affected that really prevention and treatment are inextricably linked. You can't prevent it in youth if you don't address it in adults. Finally, obesity, and that's where I've spent the last decade of my career, where there is a hugely disproportionate impact on underserved populations. There are important cultural differences because food and body image norms that are different in different communities require careful consideration, and the complexity of this problem really has let it get out ahead of us, honestly, and it requires a great deal of trust and collaboration. Well, I'd like to share with you before we go into the discussion a few key principles that I've learned through my work in advocacy and collaboration. And one is, upfront, partnerships require a shared agenda. It's important to understand where the common agenda exists and also to acknowledge where interests diverge, because trust and integrity in these partnerships are absolutely essential. Generally speaking, I would say that superficial financial relationships are seldom productive. It winds up not serving any of the partners well. But there are some encouraging trends out there, I would say, and we heard some of those this morning. First of all, I would mention patient-centered, consumer-driven healthcare. PCORI is a part of that. A lot of the innovations under the Affordable Care Act really speak to an emphasis on patient-centered care. mHealth tools, I heard that mentioned this morning, to empower consumers, can be a powerful source of change. A focus on health literacy. Healthy People 2020 includes specific goals for health literacy, and I think those will be very important if we live up to the challenge of those goals. And finally, I think there are a lot of different ways that there is potential for improved access to quality care. So where do I see opportunities for partnership? I see opportunities lying with efforts to empower underserved consumers. There's certainly a lot of work going on there right now with the implementation of the Affordable Care Act. Health literacy initiatives, there are opportunities for partnership with corporate communications professionals. And then finally, increased access to needed care offers important opportunities for partnership. And with those few thoughts, I'll turn it over to our moderator.
Thank you all for all of the insightful information that you've given us about all the work that you're doing to address health disparities in marketing. Now I'd like to open it up to the floor for questions.
Hello, good afternoon. This is somewhat relational, but really I'm seeking recommendations about how to be a better advocate for your own health. I have health care. A big problem I have is either the inertia of the doctors or their staff, and the staff seem to be minimal functioning in terms of their awareness of how to relate to patients. And I'll give you an example. I'm supposed to be searching for the procedure code for the BRCA breast mutation test I like to have, but one of the doctor's staff actually called me up and said they don't know the procedure code, and I have to find the procedure code and the testing facility. I've been calling different testing facilities and actually working with my healthcare company, which shouldn't they be able to tell me the procedure code? And somehow that seems to be like a breakdown in the chain of responsibility. And in my busy life, I have to somehow keep trying to find a testing facility that has the appropriate procedure code. Apparently, my healthcare plan provider could not tell me this, and neither could the doctor's office. So what strategies are out there to educate doctors and their staff?
So thank you for the question. I can certainly speak on behalf of Baxter. I know that situation is certainly more common than we want to acknowledge. From a training perspective, as it relates to the organization and the physicians, we conduct numerous programs such as peer-to-peer events. They are both clinically focused and primarily clinically focused and product focused. Where there's not probably enough focus would be on that relational aspect. So as we dig further into those strategies, and look into the clinical aspect and the product aspect, I think that's a call to action for us to even go in further as a relational aspect. You're welcome.
And just one other reaction that I had as you asked that question is think about what you'd go through if your car needed repair, say a repair that's covered by insurance. You'd go someplace and they'd know exactly how to deal with your insurance, and they'd get it done, and it'd be invisible to you. And that's a consumer-focused business model. You go to the doctor where, frankly, they're frustrated with dealing with all of these codes, and it's a mesmerizing system, and and they find themselves asking you, and I wouldn't know a BRCA code from nothing, but somebody ought to know it, and it ought to just work, because the point is not to feed the paper or the system. That's where I see there is opportunity that lies ahead to be more consumer focused and take the mystery out of it so that the energy goes in actually delivering good care instead of feeding stupid paperwork.
Excuse me, in the interest of time, This unfortunately will have to be the last question, but will our panelists be around later for people to ask you questions individually? Okay.
All of you seem to represent public for-profit companies. So I'm as a guy who represents public for-profit companies, how do you sell your management that this is in line with profit generations for your companies?
I can answer that. So I work at AZI. That's actually an important component. I work in the obesity space. And one of the things that we've realized as we talk to patients and to healthcare providers is the lack of education on just understanding the disease state as a whole. So for us, it's not strictly on just educating on utilizing our product, but how we can engage and interact with the community to understand obesity as a whole so that people will take action. So we support advocacy organizations on disease awareness like the Obesity Action Coalition. We partner with those types of organizations where we have shared agendas in order to close the gap. One of the biggest things that we're finding and insights within obesity as a whole is the conversations don't even take place between physicians and patients. So what we do is we look at and survey both patients, consumers, as well as physicians. We identify those gaps, and as part of unbranded disease state awareness, we actually publicly reveal that information so we can start getting that conversation started. It's easy to sell to our senior management because they understand if conversations don't occur, nothing in terms of treatment options will even be considered as part of that conversation. So there's just a lot more that needs to happen depending on where people are within education and disease state. So it's kind of easy to sell that and to support unbranded initiatives as well.
Just to complement that point very quickly, I think that one of the biggest challenges that we faced is the fact that our organization is successful, and we continue to be successful and not explicitly focusing on this. So the call to action that we have is we look at the emerging markets. If we go back 10 or 15 years ago, it was about the emerging markets. You had to go there because it was so much opportunity. It was so much trapped growth that we had to get after. As we think about that frontier, that emerging market frontier is quickly drying up. So what's the next frontier that we go after? And it sits right here in our own neighborhoods. It sits right here in our backyards. And those emerging markets, many similarities to what we go after are now the multicultural markets. It's the multicultural markets.
And I would just add to what both of the panelists said. I think Nima mentioned a shared agenda, and in terms of selling it to management, I think if you can identify a clear shared agenda, that takes care of an important piece of the job of selling in a commitment to partnering with communities, but it has to be a genuine shared agenda.
And it's also holding them accountable to our mission as an organization to save and sustain lives, and that's every life that we encounter.
Well, thank you so much. I'd like to give a round of applause to our panelists. Thank you for that information.